Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast. Today, we're discussing the latest evidence regarding a physical therapist's ability to directly refer for musculoskeletal imaging. If you are a physical therapist, you know that this is an exciting time for the profession, as we're seeing a lot of momentum and movement in really expanding and growing our scope of practice as licensed and doctoral trained healthcare professionals. This includes topics such as psychologically informed care, nutrition in physical therapist practice, primary care physical therapy, and the topic of today's episode, which is the expansion of state advocacy for imaging referral by physical therapists. Our guest today, Dr. Lance Mabry, is a physical therapist who's at the forefront of the topic regarding the integration of musculoskeletal imaging into physical therapy practice. Lance is an assistant professor at High Point University, where he teaches primary care as well as diagnostic imaging in the Doctor of Physical Therapy program. On today's episode, we'll discuss the physical therapist's ability to directly refer for musculoskeletal imaging. There'll be lots of information on the clinical utility or the usefulness of imaging in physical therapist practice, but we're also going to touch on state advocacy rights for imaging by a physical therapist. As you realize, the rights for imaging are dictated by our State Practice Act. As physical therapists, we each have an individual or distinct State Practice Act. If you're interested in state advocacy rights and the ability for a physical therapist to refer for imaging, I'm going to include a link in the show notes, which you can find at the Integrative Pain Science Institute. This document was created by the American Physical Therapy Association in 2021, so it's pretty updated. And the title of this document is an APTA state advocacy resource. So this is a resource that you can use if you're a physical therapist and you're working with your State Practice Act to help expand the rights of physical therapists in the realm of imaging. This document will list out which states have imaging rights for physical therapists. There are about 10 now, so this document is almost up to date. But the most important part, on page 2 of this document, the APTA actually lists an APTA model legislation on imaging referral. So let's say you're in a state where you do not have imaging rights. This is the model, in essence, that the APTA is recommending that you pursue to expand imaging rights in your state. So again, this resource is freely available on the website at the Integrative Pain Science Institute that's attached, of course, to this podcast episode. Okay, without further ado, let's begin with Dr. Lance Mabry and learn about a physical therapist's ability to use imaging in physical therapist practice. Hey there, Lance. Thanks for joining me this week on the podcast. It's great to have you here.
Well, thanks so much for having me, Joe.
I'm excited to talk about this topic. There's lots of progress being made in the realm of imaging for physical therapists in the musculoskeletal realm and, of course, other realms. A lot of what we're going to talk about today is in a paper that you just published. I want to make sure we point everyone to it so they can reference it. So the title of that paper is Physical Therapists Are Routinely Performing the Requisite Skills to Directly Refer for Musculoskeletal Imaging. You can all find that in the Journal of Manual and Manipulative Therapy in the August 2022 edition or issue of that journal. Obviously, like when you start to write up a manuscript or have an idea for a manuscript, there's something that kind of inspired you to, look into this. What inspired you about this particular topic for PT practice?
Yeah, I think, I've always been fascinated about how physical therapists interact with imaging. And I think part of it was when I first got to a clinic, I think, I knew a lot of the rules as far as, the Ottawa ankle rules and the Ottawa knee rules. But a lot of our patients don't fit that. A lot of our patients have, chronic symptoms and things like that. So I did a lot of self-study and I got a lot of mentorship from Mike Ross, who was my CI and still remains my mentor to this day. trying to get a better understanding of, which imaging to order and when to order it and how to order it and things like that. What started off just more or less as trying to build my skills just became a passion over time. And I would see how, how you could use, imaging referral to really expedite the patient care, to really help with patient management. And when PTs were prohibited from using those skills, how the patients kind of, went all over the medical system. And it reminds me of those family circus cartoons you used to see in the papers years ago, where the mom asked the kids to go next door to pass something off, and he runs all over the neighborhood and goes through the playground. And that's what we're seeing with our patients. I remember distinctly one I was seeing. A patient came in with like 2 days of back pain, saw primary care. They ordered an MRI right off the bat. It was like a small, broad-based disc bulge. It wasn't really much of anything. They got the imaging. They sent him off to surgery. And when the surgeons saw him, they're like, well, this isn't anything surgical. Like, we're not going to cut this. So then they pass him off to pain management, who's going to do a dorsal rhizotomy. Luckily, the patient had enough foresight to kind of say, well, no, I don't want to do that. Like, I've had back pain for 7 days now. Let's go see PT, and came in to see me, and we was pretty straightforward, mechanical, central, no low leg pain. I manipulated his spine, and he felt great. I saw him one other visit, and everything went away. And they were sending him for surgery and pain management. So when you look at that arc and how many places he went and how many people he saw, and the amount of healthcare dollars both spent by the patient and the system, it's just crazy when we can get the patients there faster and with less healthcare utilization overall. And so because of that, it became a passion with me. And I think that you'll see, in the evidence that we're looking at now, I think the Jenkins et al. Article that came out in Spine Journal a couple years ago looked at how many patients are getting imaging ordered appropriately. And one of the things we're hearing is that there's a lot of overutilization of imaging. And sure enough, in Jenkins' article, I think it said that their stats are a little bit difficult to see if it's 1/3 or 2/3, but essentially it's something along the lines of 1/3 of patients actually needed the imaging, and 2/3 it was extraneous. We hear that a ton, but what we don't hear in the Jenkins article, which was so unique, was that 2/3 of patients that had red flag findings and needed imaging didn't get it.
Mm-hmm.
So this concept of overutilization of imaging is not really correct. It's more the imaging is used inappropriately. It's both overutilized and underutilized simultaneously. And that's because it's being utilized by people that, respectfully, this isn't their strength, the musculoskeletal care. And there's nothing wrong with that, right? The people that are utilizing the imaging, primary care providers, they're strong in so many other things that we're comparably weaker at. But this imaging piece we're a lot stronger at. And when you look at the comparable studies from physical therapists as far as appropriateness, you look at the Keel et al. Article, the Crow et al. Article, the appropriateness for physical therapists is in the 80s to 90s% as opposed to the 30ish some odd percent in the Jenkins article. When we look at accuracy of imaging, that our diagnosis is matching what we're looking for in imaging is what ultimately shakes out. When you look at the Moore et al. Study, no difference between us and orthopedic surgeons. I think physical therapists in the 80% diagnostic accuracy range on imaging versus non-orthopedic providers are kind of sitting at 34%. So my view on it is all the ills that people say about imaging. It's overutilized. We spend too much money. We over-irradiate patients. Yes, all those things are true, but they're true the way it's being handled now by a group of people that respectfully don't have this skill set. Physical therapists have this skill set, and if we believe that it's overutilized, if we believe that we're over-irradiating patients, then we have to be on the forefront of saying, well, then give us the responsibility so that we can order it appropriately as based on the evidence, and we can drive some of these stats down.
It's a great introduction. I like the, kind of two sides of the coin, that we're not just overutilizing, but at times we also underutilize something that should be very appropriate for the care, probably of acute pain and potentially chronic pain, depending on what the condition is and and what's happening. Just talk to me a little bit about, so you mentioned orthopedic surgeons or professionals in there. You mentioned primary care physicians. Obviously, as physical therapists, we have intimate relationships with both of those groups. What is happening in the world? What is the research? What does the data really say about primary care as far as a primary care provider being able to manage musculoskeletal health conditions versus a physical therapist?
Yeah, there's a good amount of research on that. So obviously, Childs et al. Did that study. I think it was back in 2005, either in military medicine or BMC, musculoskeletal disorder, something like that, where he looked at physical therapists' knowledge of musculoskeletal conditions, and he compared it to all sorts of physicians of various types. He also looked at physical therapist students and things of that matter. And essentially what they found was that physical therapists and their musculoskeletal knowledge was second only to orthopedic surgeons. Obviously, all other physician groups, physical therapists did better than. The other thing that was interesting in that study is that the same held true for students. So I don't think that physical therapy students give themselves enough credit as far as what they know, but physical therapy students actually outperformed all the other physician types as well. That's kind of been echoed in I know that was a physical therapist run article, but that's also been echoed in the physician research. Physicians have looked at their musculoskeletal competencies and they've talked about feeling, not feeling confident in this, not having the skill set. A lot of physicians are saying that they got no musculoskeletal training at all. The evidence out there says that, musculoskeletal training in medical school, nursing school, PA, you're looking at roughly 8 to 12 hours of musculoskeletal training for the entirety of the body, which again, it's not digging on any of these professions. Their focus is not necessarily in musculoskeletal medicine where ours is. So just like they're going to be better at, earaches and rashes and colds and things like that, we're going to be better in the musculoskeletal space. So one of the interesting articles I think I cited was they were trying to look for solutions to this. They essentially acknowledged that, there's a problem here. We don't have this skill set for musculoskeletal medicine, but yet the proportion of patients that come through the door that are complaining of musculoskeletal pathology is comparably high. And, they're looking for solutions. And how do we do this? Can it be filled by PAs? Can it be filled by nurse practitioners? And, the studies that they did kind of found not great results with that. And meanwhile, physical therapists are sitting here and like, we're here and we're ready and we're ready to be plugged into this role. You don't need to look for a solution. We are the solution. Like, plug us in and let's go.
Yeah. It's interesting because as I listen to you speak, obviously this is all resonating well with me because I've been through a DPT program, but there may be someone listening to this podcast, another physician or another healthcare provider that is saying to themselves, wow, I never even knew that physical therapists could that they even learned about imaging in school on any kind of level, right?
Yeah. So imaging is a mandatory part of the physical therapist education. It's mandated by CAPTE. So CAPTE is our accrediting body for entry level education. It's on our national licensure exam. It's also part of the mandatory educational set for residencies and fellowships, as well as the board certification exams as outlined through the description of specialty practice. So physical therapists are getting this throughout their education. And one of the things that we're seeing is, I started my physical therapist career in the Air Force, and the majority of Air Force physical therapists are actually civilian trained. So the Army has a different model. Most of their PTs go through Army Baylor. I was one of the few Air Force PTs that went through Army Baylor. And what I can tell you is there was no special training I got on imaging at Army Baylor that I think any other school is getting. I think it was, reasonably basic. We hit the basics and we had enough that we were reasonably competent in practice, but there isn't any secret sauce the military is getting. And I think one of the big things is, we get the training just like the civilian sector does, but then we're actually put into an environment where we can utilize the training.
Yeah, that's true.
So on the Air Force side, we're getting these PTs coming in from all these civilian programs. Certainly they're new grads, so there's some level of mentorship that goes on with that, just like you would with any new grad in any clinic anywhere. But these guys come in from civilian programs and they're off and rolling and doing great after some mentorship. So civilians are getting this as well.
Yeah, it's a great point. I mean, because obviously when they say you've graduated, you now have a license to practice. In the military setting, you have an opportunity to practice these skills that we're talking about, where outside that setting, PTs may not have that opportunity, and they may have to refresh their skills, let's say, before going into a setting where they can apply them, so to speak. But I think the take-home message is that we're graduating with these skills. They're on our national board exam, and new graduates are competent to utilize these skills. So in this study, I mean, obviously it's a survey that you did, 4,800 subjects, which is huge, which is a very large study. I think it's the largest study that we have on this topic. Tell us what some of the findings were from that study.
Yeah. So one of the things, if I can start off, one of the reasons that we actually dug into this was we were, looking at different practice acts and how to change rules and everything else. And essentially what we found was, there are three things that essentially can change rules or change practice acts. And those three things were, you have to show that there is entry-level education in whatever skill. So we just talked about that. You have to show that there's continuing education availability. We touched on that with residency training and fellowship training. Certainly the more traditional continuing education classes, like I teach imaging continuing education for Redefined Health, those exist. But then that third element that's required is to show that these skills, in this case referring for imaging, is being utilized in routine practice. And that's a little bit harder depending on where you live, because if it's explicitly prohibited, how do you show that it's routinely being utilized? Mm-hmm. So the idea behind this was, okay, well, and a lot of it was really inspired to me by the state board director here in North Carolina, Kathy Arney. The idea behind this was, okay, well, if we can't show that physical therapists are actually pulling the trigger on referring for imaging, can we show that they're doing everything else? Can we show that they're doing all of these other things and they just aren't putting it into the system because they're prohibited? And to that end, we got together a group of PTs and we kind of talked about, what are the skills that are required for imaging? And, there are certainly some things that lead up to the imaging itself, but then there's also the act of actually requesting or referring for the imaging. And then there's also a lot of responsibilities that come with that. It's not just ordering the imaging, but then what do you do when the imaging comes back? What do you do with that? So we got, three senior physical therapists that had experience either referring for imaging or in a practice where you'd have to request it or things like that. And we came up with 9 skills. And a couple of the skills happen before the imaging order itself. The first one is triaging the patient. Do they even belong there? If they're having a heart attack, I'm not going to order imaging on them. They belong somewhere else. So that's kind of that first step of, do they even belong in your house? The second one is, once they're there, are you using evidence-based imaging guidelines to kind of help you make that determination? And there are a number of them out there. Obviously, we talked about the Ottawa rules, but also the American College of Radiology appropriateness criteria is kind of the gold standard for this. Our third one is considering the risk benefit for the patient. So all things considered, even with the evidence, does it make sense for this particular person for whatever reason? The fourth one was the actual request for imaging itself. So if some people might be able to refer directly to radiology, or some people might be, referring through an intermediary. So they're not referring for imaging, but they are contacting a PCP and saying, yeah, I need imaging. And then it's subsequently ordered. And then the remaining ones kind of fall on the responsibilities that happen after that. And that's, suggesting an imaging modality itself. So it's not enough to say you need an image. Do you want radiographs? Do you want an MRI? Do you want a CT? And why do you want those? Once the imaging report comes back, reviewing that report, then subsequently educating the patients on the findings. Because if you order it, now you're responsible for telling the patient what's going on. Taking the findings and then integrating it into either your treatment plan or your patient management plan. And then lastly, and this is one of the important ones that shakes out for the board members, is is referring patients to another provider for anything that's outside of the scope. So if something shakes out that it's not what you thought it was, it's, something non-musculoskeletal, maybe it's a tumor, something like that. Are you taking it upon yourself to then, refer the patient appropriately where they need to go? And so once we kind of established that these were the skills, we wanted to send it out there. And I was looking primarily at North Carolina. That's the state that I live in. And the thought was, well, if we push this out, might as well push it out nationwide and kind of see where things are. And the idea behind this was to really engage the APTA state chapters on this. Each chapter in the APTA has a president. And actually, during this process, I actually discovered that there is a council of chapter presidents where the chapter presidents are in this organization, and then there's actually a president of the president within the organization that can kind of help distribute this. So we reached out to all the chapters. We reached out to a number of APTA sections. Ultimately, many of them pushed it out. And then that's really what helped drive this. And one of the interesting things we learned on this process was, as we were reaching out to some of these state chapters, they were telling us, wow, that this is a great idea. We can use research to kind of help our advocacy and legislative and those kind of things. But we don't really have a process in place on how to push this out and the like. So it did spur some interesting conversation. And I'm hoping that those that participated understand that now, okay, well, shoot, if we have something in place, we can go ahead and get this data to help our advocacy issues.
And I guess we should just probably touch on the advocacy part just for a moment, because we're both PTs and we're talking to other PTs. How many, you may not know the exact number, but how many states is our jurisdiction kind of free and open to this type of approach?
Yeah, so I think that's a great question, Joe. And right now, I think there are 10 states that allow imaging in various capacities. I'll try my best to rattle them off by memory, but hopefully I don't miss any. But I know Wisconsin, Rhode Island, and North Dakota, I think, are all ones that have it in their Practice Act. I think it's limited to solely radiography for those states. Utah has it in their Practice Act as well, but it actually resides in the Radiotech Practice Act, which essentially says that they can accept referrals from us, which is interesting. It doesn't sit in PT; it sits elsewhere. Yeah. West Virginia passed it at the board rule level for all imaging modalities. So did Colorado for all imaging modalities. Board decisions have been dropped in Maryland, DC, and New Jersey. None of those are restrictive. And as far as modality, and that's one of the things we're seeing is, if it passes through legislation, there's a political process that goes on there. And because of that, there are things that have to be, debated and given away and things like that. But when it's done at the state board level, a lot of time, there's no politics with that. It's just looking at what the evidence says, and then they kind of implement it. So those that have gone through legislation, with the exception of Utah, are all limiting to radiographs. Those that have gone through the board are all allowing all imaging modalities. So the answer might not be Practice Act change. The answer might be at the board. It all depends on what's going on with the state. And those that are trying to get plugged in on this, what I would tell you is don't do it on your own. In fact, you can actually have really bad consequences. If you ask the question the wrong way to the board or things like that, you can actually trigger a rule that can set the profession back. Make sure you're working with your state chapter. So get with your state APTA chapter, see where they're at. If you want to lead it, they may or may not be willing to let you lead it if it's something you're passionate about. Yeah,
these things are very complicated. I mean, in the state I live in, New York, the Practice Act sits in a different place than the actual board. So it can be complicated in certain states. In other states, it seems like it's a little more fluid and can happen, hopefully, potentially easier.
I heard, so one more, I heard Arizona passed imaging, although I don't, I haven't seen it. I don't know where it is. I don't know what it is. I heard it. I just haven't found it anywhere yet. So stay tuned, Arizona.
Yeah. And I guess, from there, we're a bit off your study. I want to come back to your study, of course. Sure. But I guess from there, then the question always begs, will an insurance company cover that service, so to speak? So if a physical therapist is referring for a radiograph and it's in the Practice Act, will the insurance company cover it?
Yeah, that's a common fear that physical therapists have, but none of the research is shaken out on that. So Keel et al. And Shuda, hopefully I'm not fouling up Dr. Keel's name. I don't know if it's Keel or Kyle, but Aaron Keel out of Illinois. So he reported that none of their imaging was declined for reimbursement. I know Wisconsin looked at this as well, and they surveyed their PTs that were ordering imaging. And while many of them said they feared that imaging wouldn't be reimbursed, they asked them, did anybody have any experience of imaging being reimbursed? And they all said no. So it appears to be more of an issue of fear of a lack of reimbursement than what the reality is, which is these are getting accepted. So in fact, talking to different radiological imaging centers, a lot of these guys are thrilled to have an extra referral source. So there might be some internal things that kind of have to work through to get the referral source kicked out, but a lot of times they're happy to get referrals from people.
Great. It's really good to hear. I think it's also important that patients hear this as well, because they're obviously in this process and looking for, the most effective care. So that's important information. Okay. So you have this survey about 4,800 subjects, and you have these 9 skills that are associated with the imaging referral. So bring us to kind of the punchline here. What does the study tell us?
Yeah, well, I think one of the first things we wanted to look at is, where the heat was with imaging. What we found is kind of what we expected, is that most people that are using imaging skills are sitting in that orthopedic and sports setting, mostly the outpatient setting. Comparably less so on the inpatient side, those working in rehab, SNF, things like that. Pediatrics was also comparably low. And I think one of the important the things behind that is, I think as physical therapists, we're our own worst enemy. We fight so much with each other, and we need to get kind of united. And I know when I've tried to be working on these imaging things in the past, I've been told by leaders in the profession that were kind of more in that pediatric or acute care setting, and they're saying things like, "Oh, well, why do we need this? It doesn't matter. Just get just get the physician." And it's like, that might be great in acute care, but in ortho and sports and things like that, it doesn't make sense. So if you're in one of these other settings and this doesn't seem to make a ton of sense with you, please come along with the ride for us, because it's very important to reduce imaging utilization, to reduce harmful imaging that that doesn't need to be done, things of that matter, reduce costs and the like. And then overall, what we found is that imaging was being utilized quite extensively. So I think the average number of imaging skills out of a total of we had 9 total skills. The average that were being used routinely across the entire populace of PTs was 7 overall skills out of 9. That indicates a very widespread amount of routine use of imaging skills. And that's important when it comes to advancing legislation and changing board rules, is to understand we're already doing this. We just can't pull the trigger. We're already doing all of these things associated with imaging, but we just can't drop the order. It's an administrative burden, but it's not stopping us from interacting with imaging. We are interacting with imaging. We just can't do the administrative hurdle. The other thing we found was that 28% of physical therapists were performing all 9 imaging skills routinely. And this is an important one, especially for state boards who are focused on patient safety, to understand. The fact that 28% of physical therapists are already performing all 9 imaging skills routinely is a very large and very substantial number, and suggests that these are widespread skills that are being utilized regularly. And it would justify the expansion of jurisdictional scope.
It also points to the rather positive clinical decision-making that DPTs are making as a result of their education and using those skills in practice to help people.
Yeah, no, that was one of the things we wanted to look at too. I'm sure you've probably seen on different chat rooms the chatter that says, "Oh, well, the DPT didn't do anything, and they're
Right.
not getting anything extra, and they're no different, and whatever else." And and there's been a lot of studies that have kind of dug into this a little bit and have already proven it false. But our study does that as well. So essentially, what we found was DPTs utilized imaging skills significantly more commonly than their MPT counterparts. And both DPTs and MPTs used imaging significantly more than their BPT counterparts. That's not in any way meant to be insulting to the NPTs. It's not in any way insulting to the BPTs. In fact, both of those groups actually still utilized imaging very commonly. It was just that the DPTs did more so. And a lot of that comes with the advancement to the DPT, where we actually added on imaging through CAPT guidelines. So to say that the DPT added nothing at all, it's not grounded in fact. And that's going to become very important. Like we said, we have 10 states now that allow PTs to order imaging. We have more. I know multiple states. I'm not going to tell you who, but we have multiple states that are working on this as well currently. This is going to be the future of the profession. So the DPT is going to be what ultimately gets us there. I think the other thing that's important to understand with the DPT is it serves as the foundation for the advocacy in this position. So every time we push for legislation, every time we push for board rules, the opposition, which primarily comes from the physician groups and the chiropractic groups, their main opposition point is that physical therapists aren't trained, we're not educated, we don't know what we're doing, and therefore we're going to hurt patients. And it's so predictable. It's the exact same thing every time. And when that drops, we just drop down the DPT. A lot of the opposition just kind of fades away, right? So legislators, oh well, we're doctorally trained. Legislators, okay, I'm not going to listen to that nonsense. These guys are trained on weekends and hurting people, right? So without the DPT, getting these advancements would be very difficult. And you're actually seeing that when you look at the board rules in West Virginia, when you're looking at the Practice Act in Wisconsin, the DPT is specifically in there as being allowed to order imaging. It's one of the qualifying criteria. So this has power with legislators, it has power with boards, and it's going to take us to the next level.
So you mentioned the future, and obviously some of our PT professionals are already doing this, but if there are therapists out there in any state, some states, they may obviously have this in their jurisdiction. Some states, they may not have it, but they can still practice some of those 9 skills. What advice do you have for them as far as starting to use these skills, or I guess pursuing, the regulation part of it?
Well, I mean, if they're in a state that allows it, one thing I would recommend is getting a mentor. There are mentors available through the APTA imaging SIG through the orthopedic section. You just have to plug it in there and kind of connect with somebody, or even a senior PT in your clinic that has some more of those skills. The other thing to possibly polish those skills, and we actually found this in our study, is that residency and fellowship trained physical therapists are performing significantly more imaging skills than those that aren't residency and fellowship trained. So looking at potentially a residency or a fellowship. The other thing I would recommend is look at every single image. When your patient comes in, you should be looking at all of them. If it's relevant to what they're coming in, whether you ordered it or whether somebody else ordered it, you should be looking at it. And there's no excuses of hiding behind, well, I don't have an EMR system that lets me access it. Okay, then tell the patient to bring in the CD.
Sure.
And they'll bring it in. And there's no excuses of, well, my computer doesn't have a CD player. Go buy one. They're $5. They plug into your USB, and now you can look at imaging. And taking that time and looking at the imaging and looking at the radiologist report. One of the ways that I really polished my skills was, I would my first 6 months really in the clinic, I would look at the radiologist report, and then I'd look at the imaging and I'd try to find it. Where is it? And I'd look and look and look. And then if I couldn't find it, I'd have to, tap a friend and help me out, And, I did that. It took me about 6 months to the point where everything the radiologist was saying, I could find pretty quickly. And then at that point, it flipped. At that point, I looked at the imaging first. I saw what I thought was important, and then I compared it to the radiologist findings. And then I was what did I miss? And if they found something I didn't, I'd have to go back and look at it. That took me another 6 months or so. So it was a year in total. Those were long nights. I'm going to be honest. I mean, it took me a bit to kind of get through that. But once I got through that, then all of a sudden I was finding things that were missed by radiologists, right? So just like we miss things as physical therapists, it's not a ding on the radiologist. They miss things on occasion. They are better than we are at this, but we also have a patient in front of us. So, and two eyes are always better than one, or two sets of eyes are always better than one. So, the radiologist will always be better than the PT, but the radiologist and the PT will always be better than the radiologist alone. And there's nothing wrong with that. So looking at the imaging, seeing what you see, I can tell you, I found displaced fractures that were missed at the first read. I found all sorts of things that were missed on the first read. So take a look at it. It's completely appropriate. And then the last thing I would tell you is don't be afraid to reach out to the radiologist. If there's something you have a question on, you'll be amazed. I mean, the radiologists are thrilled to see that you're looking at their stuff, and they're thrilled to know that you're integrating their words into your clinical care. I mean, if you're calling them 5 times a day, they're probably going to hang up. But if you have something that comes up every couple of weeks, reach out to them, say hello, see what they think. And what I found is that the radiologists are incredibly inviting.
So before we wrap up, Lance, of course, we point everyone to that paper. It's in the 2022 August issue of the Journal of Manual and Manipulative Therapy. Everyone can read that. If you're a PT and you're working on legislative action, you might need that paper to help with some of the work that you're doing, that you and your colleagues are doing in this area. And then Lance, for those of that are watching the video, of course, everyone can see this video either on YouTube or on the website at the Integrative Pain Science Institute. Over your left shoulder, there's an image of a pelvis with a dislocated total hip replacement. Why don't you give us the quick 1-2 on what that is about?
Oh yeah, this is a great case by 2 of my PT students, Zach Mathian and Lauren Katina. I believe I collaborated on this with a PT who's brilliant, Tracy DeShavi. And essentially, it was a patient that had multiple total hip dislocations over and over again. And when you look at the history of total hip dislocations, a lot of it was tied to angulation of the hardware, and are you adhering to the internal rotation blockage or things like that. And some of the more recent literature has actually shown that patients that get a total hip, they're more prone to dislocate if they also have back pathology. And those that don't have back pathology, their total hip is more likely to take. So the research that's coming out, it's actually the surgeon research is essentially saying, well, if that's the case, should we surgerize both the hip and the spine simultaneously? Or should we do them in series where we surgerize the spine first and then we surgerize the hip? And when we put this out, our idea behind this was, well, wait a minute, let's introduce this to the physical therapy literature. And maybe there's possibly a preoperative lumbar rehab protocol that we can put in that could prevent some of these things. So I think that was our idea behind introducing it. I would love to see it get some traction, and hopefully it can stop some people from getting dislocations.
So a healthy lumbar spine may prevent hip dislocations, status post-total hip replacement.
Yes, sir.
Really interesting. Lance, it's been great having you here this week on the Healing Pain Podcast. Let us know how we can follow you and your work.
Sounds good. Well, thank you for having me. Probably the easiest way to get a hold of me. I'm on LinkedIn, Lance Mabry, if you want to look at me there. But if you're interested in getting any imaging education from me, I teach continuing education courses at Redefine Health Education. That is a veteran and woman-owned company through Katie Obright, who's absolutely brilliant. We also have some primary care education through there, which I know primary care is a passion of yours, Joe. So those would be the places to find me.
Great. So we'll link to everything in the show notes. Of course, you can find that at the page on the Integrative Pain Science Institute. If you're someone interested in imaging, if you're a physical therapist or you're working on this, make sure to share this episode with your friends and family on Facebook, LinkedIn, Twitter, or Instagram, or wherever anyone is talking about imaging in physical therapist practice. I'm Dr. Joe Tatta. We'll see you next week.
Thank you so much.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science orthoinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.